Thank you all so much for joining me tonight. I know how busy everybody's schedules are, and so I just really appreciate all of you carving out this time and space to join tonight. Really excited about this workshop. This will be about planning for birth after loss in partnership with RTZ Hope. I think this is the first workshop of this kind that RTZ Hope has had. And so I'm just really grateful to be here, really grateful to all of you for joining. Okay. All right, so here's a quick agenda for tonight. We'll start off with an introduction and I'll share some of my hopes and goals for the workshop. We'll spend most of our time tonight just talking through understanding your birth options and identifying your preferences as far as it comes to your birth. And we'll close off tonight with a Q&A session and some closing thoughts. We are recording right now so that this information can be shared afterwards and also I think be on the RTZ Hope website for reference in the future. But if you haven't heard me say it yet, the Q&A portion of the workshop is not going to be recorded. So at that point, feel free to come off camera if you want and speak any questions that you might have. That part will not be recorded. Okay, so a little bit about me. My name is Yuan. I'm a proud mom of 3. I live in Brooklyn with my husband, Delwyn, and our 2 living children, Bennett and Logan, a boy and a girl. And I am a doula who specializes in pregnancy after loss and bereavement care. And I'm here tonight because of my middle son, whose name is Yuan Paxton. And Yuan was stillborn at 38 weeks. In April 2023. The name of my doula practice is called A Little Peace, and that's in reference to Keelan's name. Keelan means little, and Paxton means peace. And so, yeah, that work is really kind of in honor of him. And I welcomed my daughter in May 2024, so that's Logan, our baby. So if you haven't already, would love if you could share, who volume is okay, but it's muffled. Sorry, in the chat. I'll try to address that in a second, but in the chat, feel free to share your name and what brings you here tonight, whatever, if you feel comfortable.
My purpose and goals for tonight. Pregnancy after loss, I think I continue to be so just like humbled and in awe of everyone who chooses to go on that journey. I know that I don't have to explain this to you almost likely, but it is hard. It's a hard road. And I think that preparing for birth when you're pregnant after loss is also just incredibly daunting, or can be. And so my goal with this workshop is really to provide some of the education and birth information that you might find useful, things that you might find in the traditional birth class, but that are really tailored to the impact of your loss on the birth and pregnancy. And I really hope that you walk away feeling like tonight was for you. I think that in so much of the pregnancy and birth world, when you've experienced loss, if you feel like, things aren't for you anymore. And I really hope that just by joining tonight, you find that, there is a little bit more of a sense of community just by seeing that there's, 25 other people on this workshop who might, share a little bit of your story. I hope that you come away from tonight thinking that the information that you hear here is, based in acceptance, that whatever your preferences are valid, and that, my goal would be to support you in whatever, I hope you feel good in making whatever decisions are right for you and for your birth. And I also hope that you can feel a little bit more empowered. I think that this PAL journey can be very overwhelming, and it can easily feel like so much is out of our control. I hope that you get a sense of a little bit of a sense of empowerment back as you learn more about, experiences that might be tailored to you, and are able to, come back to more of a sense of joy in this pregnancy if that's where you are. Kind of building on that, I say this often, I think PAL feels hard because it is hard, and sometimes it can be easy to judge ourselves for our feelings, which makes it just that much harder. It can be really easy to, think if you're pregnant again, this is all that I've wanted, and all that I've been looking forward to. Why does this feel so difficult? And I just encourage you to speak to yourself and treat yourself like you would if it was your best friend going through it. You would listen to your best friend's fears, you would validate, what they're feeling, you would support them, and, you are deserving of that same kindness for yourself. Sometimes it can feel hard to do it for ourselves, even though we know we would be capable of doing it for others. As far as this workshop goes, I'll try to repeat this, but, take what serves you and leave the rest. I'm sure I'll take a second in a bit to just kind of quickly scroll through some of your intros, but everyone is coming from a very different set of facts and circumstances. Not every thing that I say in this workshop tonight is likely going to apply to you specifically. So take what serves you and leave the rest. It'll be kind of a lot of information. It was not easy to think about paring down some, all the things that I wanted to talk about into the time that we have tonight. If that information starts to feel overwhelming at any point, I do want you to, step away, take a break. You can come back to it when you're ready. Like I said, there will be a recording that's shared later. You'll get the slides as well. So that information will be there when you're ready. And if you allow me for a second, I would love if we could just kind of take a little bit of a collective breath together, and you can close your eyes if that feels right to you, but I would love to just kind of offer you guys. So if you want to repeat after me or say it to yourself, whatever, but just I am a good mother to this baby, and to the baby or babies that came before. I'm doing my best, and it is enough. Okay. So here's a little bit of like a framework for making birth decisions. First can understand what options are available, and what the experience allocated to each option might entail. Next, you can layer on your unique preferences that you might have, like what you want and what feels right for you. And that together, your options that are available and the preferences that you might have, those come together to be your decisions for your birth. So we'll talk a little bit about understanding your options first. I want to talk a little bit about the pregnancy part of things. If you'll give me a second, I'd love to just kind of scroll through the chat and see where folks are. How many found tonight? Okay, so trying to conceive, which it sounds like some of us are coming from, unfortunately, pregnancy after loss or planning a birth after loss, in the very beginning to the subsequent pregnancy or first trimester. There's a lot to think about. One of the big ones is picking a provider, kind of even putting aside for a minute all of the kind of emotional work it takes into deciding when you're ready and how to start trying again. Even putting that aside for a bit. Picking a provider can be another big part of that process. You still have choices, whether that's an MFM, an OB/GYN, or midwifery practice. In general, you should still have a choice as to, where you feel most comfortable. My advice is, just to make sure that whoever you choose, whatever provider you choose, that you make sure they, should have ample experience, both fortunately and kind of unfortunately, supporting patients who've gone through law. And they should be able and willing to address what you need. So part of having how to, figure that out is having initial consult. You can and should likely do that. Even before you start a new pregnancy, or kind of as you're thinking about trying to conceive again, you can do something called a preconception consult. And there, your provider should be able to go over your full medical history and loss history and be able to articulate a clear plan that's, really tailored to you. Some things to think about, and we talk through potentially at these initial consults are, does it sound like they are open and, already proactively suggesting, extra monitoring, like things that might not be medically indicated necessarily, but are more so for your peace of mind. Are they, offering that proactively? Are you asking about that? Thinking about, are they reachable? Are they responsive? I think it's always a green flag if a provider offers you a direct line or email address. You're looking for kind of an understanding that you are going to need something different than, than just any other patient. At the same time, I think that this is a really good time to talk about this idea of extending grace to yourself primarily. I think that it can be really tempting to think about how everything needs to be perfect in a pregnancy after loss, in a subsequent pregnancy where you've been through loss. I remember when I was thinking about trying to conceive again, I was newly pregnant, I said to myself, like, okay, I'm going to do everything right for this pregnancy. I'm going to eat 100%, like perfectly, and eat all the right things. I'm going to work out every day. I'm just going to spend all of my energy funneled into making sure that this pregnancy is healthy and that I'm doing everything that I can. I know where that comes from, but I think that if I could go back, I would say to myself that, that's neither realistic or helpful, because I was so disappointed with myself when, life got in the way and I didn't end up, holding up that end of the bargain. So just extend lots of grace to both yourself, and I think that goes for your provider as well. Like similarly, they're living in the real world and have real life restrictions. Much as they might want to, they might not be able to spend, an hour every visit, speaking with you, even if they want to. And so I think it's helpful to sometimes remind ourselves that perfect isn't the requirement or the goal. And neither of you, not you, not your provider, have to be perfect in order to have a positive experience in a safe and healthy pregnancy. Okay, so some second trimester considerations. I think during that time, it's a great time to try and find ways to support yourself as you manage, doctor's appointments and start, thinking ahead potentially. I think this is a great time to just sort of get curious with yourself about what helps you cope, what you feel better doing. That might mean more check-ins with your provider. That might mean fewer check-ins with your provider. You might be feeling like it's really hard to bond with a pregnancy. Is it helpful to, try to do little bite-sized things, whether that's, going for a walk if you're not, full out planning a nursery, but going for a walk and, taking that something, maybe it's time boxing, how much time you spend researching pregnancy things, if that's starting to become overwhelming and you find yourself doing that a lot. And then the third trimester of pregnancy, it sounds like some of us are in that phase as well. Often that can be just a really incredibly difficult time. It's a sense of being nearly at the finish line, and yet, emotions can often be the most intense when your end goal is that close. I would say just check in with yourself often and lean on, the things that have helped you most thus far. This is really a time to just continue yourself in what's worked thus far and really double down. Your care plan in the final weeks, it might include increased monitoring, both at home, or with your provider. At home, you might be doing things like keeping track of your blood pressure or kick counting. If it's something like that that you're doing on like a daily basis, or even more than a daily basis, I find that it helps to establish some sort of schedule for yourself that works for you, a schedule or a cadence. And then you stick with it to help eliminate this decision fatigue that you might encounter where, you can't fix all day long, but you can decide that I'm going to do it, at X, Y, and Z times, or, just how it's going to work with your life and hopefully take kind of one mental thing off of your plate. With your provider, you might be going in as you head towards the last few weeks of your pregnancy, depending on what your loss history was, what your specific care plan is. You might be going in more often and doing tests like NXTs, those are non-stress tests, biophysical profiles or BPPs, are kind of like these more detailed ultrasounds that also are looking at how well baby is doing. You might be going in for extra growth scans, which is, or ultrasounds in general. And you might find that you're starting to have more detailed discussions with your provider about your birth plan. Okay. So now I want to talk a little bit about just preparing for your birth. I'll talk a little bit about what things are kind of in common regardless of what mode of delivery you might be planning. And then we'll talk about some more specifics for the planned vaginal birth and more specifics for the planned C-section birth. And I'll say this too, I recognize that for many of us here tonight, this likely is not your first birth. This may not be your first living child either. But regardless, this birth is likely to feel different. It's likely to be different. You might make different choices and it'll, more likely than not, just feel very different because of your loss history. And so part of that, I think, is understanding that and then preparing for it. And a big piece of it, I love seeing that. It seems like, there's a lot of partners on the call as well. I recommend talking openly with each other in advance about what your roles will be for this birth. I think that the role of the partner is a really tough one, honestly, for birth. And they are the person who, most likely is the only other person who can say, like, I've lost that child too. Like, this was our child that we lost. But for birth, your partner isn't the one who's centered, right? His experience or their experience is not necessarily the one that's centered. And it can be a bit of a lonely role if you feel a little helpless for the partners for birth after loss. So I think talking in advance about some concrete strategies that your partner can do is can be really helpful. And figure out something that they can do that really plays to your strength. So, some examples, there could be like physical hands-on sort of upward measures, that maybe counter pressure, maybe massage, maybe they can build a music playlist for you. Sometimes words of affirmation can be really helpful when it comes to my partner. And then this last one, I think that having your partner kind of be the one to help gently remind the medical team of your loss history and how that's healing for you, for both of you in a birth, I think sometimes feels really right for a lot of couples. And, your medical team is likely going to see loss history, relevant loss history on your chart when you go in for a birth. But just having someone else who's maybe not the person about to give birth say like, oh, we lost a baby last year. And, this is exciting for us, but also, feeling a little bit anxious and we're a little scared. And so just, thank you for understanding and being here with us. I think sometimes that role and that ability to say that feels really good for both people. A similar vein as far as visitors go, post-COVID, hospitals are, a lot more lax with and kind of generous with the number of people that they allow in your either birthing room or postpartum room. But I want, folks to think carefully about who they want in the room and make it be people who they truly want rather than. Oh, guys, sorry. Thank you for following me with this stuff. I never resumed. I'm sorry. Okay. Was that? Did you guys see third trimester or
we saw third trimester, but
you saw third trimester. Preparing for birth. Here it is. Sorry, guys. Okay, so yes, I was talking about support people and then visitors. Pick carefully who you want in the room. It's okay to say, we just want this. Those who care for you will understand, and if they have a reaction that is not what you hope for, that's okay. That's on them. That's not on you. You should pick who you want in the room, not who you think should be in the room. That goes for back at home too. Like, initial visitors in that early postpartum phase should be people who you want there, who are going to be helpful and supportive to you. Okay, and then switching gears a little bit, this is more of a tactical suggestion, but as far as packing your hospital bag goes, just remember that birth, particularly inductions, which we'll talk more about, but they do take time. And I think it's smart to plan to be away from home for, at least a few days. It could be shorter depending on how things go, but planning on that. And I think that particularly when it's a birth after loss, like this is the time to bring all the things that you think are going to be helpful to you. Like it's not a time where you feel like you have to, be a minimalist in terms of how you're packing. Hospitals aren't necessarily the most cozy and like warm, welcoming places sometimes. So bring items to make you feel a little bit more at ease and at home. I like to pull out pillows for whatever reason. Pillows in hospitals are a scarce commodity. Pregnant people typically sleep with a lot of pillows. And when you're near the end of your pregnancy, if that's you and you sleep with a lot of pillows at home, go ahead and bring some to the to your hospital and stay. Bring blankets, bring eye masks, sound machines, toiletries that smell nice, like just whatever you think that you could use to make things just feel a little bit more comfortable for you. I would say go ahead and bring. Okay. As far as communicating with your care team, something that I've noticed in my experience with clients has been that when you say a little more, it can really help your care team understand you better and understand what it is that's the root of your ask, and that helps them help you better. So I have an example from a former client. She was going in for an unplanned C-section and a little bit earlier than anticipated. And, when I got in the room, this kind of conversation about the C-section was happening. And I knew that skin to skin was something that was going to be really important to her. We had talked about that in a prenatal visit. And so I said, she wants to know if they can do skin to skin for this, unplanned C-section delivery. And the response that, we got first was very like, okay, it'll depend on how baby is. If everybody's stable, then yes, but it'll depend. Baby's here a little bit early. We're gonna be in the OR. It'll depend. And I think that once we started talking more about, the reason why she's asking is because she knows that right after delivery is for her going through the time that she's most anxious about. And she really wants that reassurance of seeing and feeling for baby for herself. She never got to do that with her loss. That was something that this is the client talking at this point, that I think is going to be really important for me for it to finally feed in. What do you think the options are going to be, given that we're, going to be in the OR, given that babies here a little bit early. And just sort of, I think, appealing to that human connection and giving that more context really helped the team say like, oh, of course, like we will do everything that we can to make sure that you get to see and feel your baby as much as possible. We can bring her over and like put her cheek to cheek with you. We can make sure that you get to touch her quickly, even if we do have to bring her to the warmer afterwards. We can narrate everything that we're doing when we're over there with her at the warmer, and like, give you a verbal rundown of all the reassuring things that we're seeing. So it wasn't that the answer was necessarily different, but when we gave a little bit more context, it helped them, get to an answer that felt a lot better and helped everyone understand each other a bit more. I think I like to do this too, not just with, requests or questions that you might be asking, but just to kind of get the team to reiterate something to you, I find can be helpful too. So oftentimes, I'll have fine facts or I'll ask for just a repetition, say more. Can you say a little bit more about your thought process on this, even if they've heard it before, and it gives an opportunity, or we'll ask the same thing for different people. And it just gives an opportunity to hear that information again, hear it maybe a little bit different way, have a little bit of a different nuance come out. And that can be really reassuring. Sometimes it takes that repetition to kind of get it into our brains, especially when we're feeling anxious and scared. Sometimes, asking your care team to say a little bit more too, can just help everyone feel like, okay, we're in this together. All right. So I'll talk a little bit more about specifics for planned vaginal birth now. As far as what to expect, as far as kind of like procedurally, initially you'll sign some consent forms, you intake paperwork. One of the first things that'll likely happen is an IV placement. I'm talking about a hospital birth. Sorry, I'll just back up. This may or may not apply to you if you're planning a birth somewhere else from the hospital. IV placement typically tends to be one of the first things that happen as well. And then placement of fetal monitors as well. Those may or may not be wired. They could be wired or they could be wireless. Those are the little buttons. I'll call out like an illustration of them in a second on the next slide. But they're like, 3 or 4 inches in diameter. They look like kind of large buttons, and they're strapped to your belly. If they're wired, those monitors are plugged into a machine on the wall with like, a cord that gives you some slack so that you can still move around a bit. If they're wireless, then they just need recharging every 4 hours or so generally. And they're there to monitor baby's heart rate. One monitors baby's heart rate and the other one tracks control. They will likely need frequent adjusting during your labor and during your stay there. You'll likely encounter nurses coming in fairly often just to make sure that they're still picking up what they're supposed to be picking up. As you move, as baby moves, sometimes those monitors just will need a lot of fiddling with. As far as your care team, your nurse will be likely your primary point of contact. They'll be in and out of the room to perform care tasks. They do things like placing your IV, administering medication. They may or may not be the ones who are checking your cervix to evaluate labor progress as well. The OB or midwife team, your like provider team that you see in the office during prenatal visits, they will be involved too. They may or may not be there for the full extent of your labor. Sometimes they might be monitoring remotely and just checking in kind of as needed. Sometimes depending on what type of institution you're at, whether you're at a training hospital or larger hospital system, residents and fellows, practitioners in training may be part of your team as well. Okay. a little overview of labor and what it entails. There's those three stages when it comes to labor. The first being is kind of what we think about when we throw around that term labor, is the dilation stage, and that's the cervix getting to 10 centimeters dilated. The second stage is pushing. That can be anywhere from a few minutes to a few hours. And the third stage is one that's, often overlooked because it comes after baby is delivered, and that's delivery of the placenta, and that's generally, no more than a few minutes, and usually straightforward. Dilation then is broken down into 3 phases: early labor, active labor, and transition. And both of the entirety of this stage can vary widely in how long it takes, anywhere from a few hours to a few days. As far as the definitions of early labor versus active labor, doctors usually kind of define that a little bit different than how we do when we're speaking about labor conversationally. So ACOG, that's the American College of Obstetricians and Gynecologists, they define early labor as 0 to 6 centimeters and active labor as after 6 centimeters. And that's based on more research showing that 6 centimeters is roughly the point at which labor kind of quickly speeds up, an inflection point. And it's a little bit later than originally thought, around like 3 or 4 centimeters. The only reason that's relevant for you is that I want you to take away that it's important to be patient, and that length of labor can be a while, particularly if you're in that early labor phase, between like before 6 centimeters. It's not abnormal for it to take upwards of several hours to dilate a centimeter until you're around 6 centimeters, and then after that, an hour or two to dilate a centimeter after that. As long as baby is looking good, as long as they're doing good, that length of time is not an issue. Okay, I'll take a minute and talk about induction of labor, because that's a pretty common choice overall, and kind of an increasingly common choice overall, and even for just a run-of-the-mill pregnancy, and definitely a common choice that I see for pregnancy after loss, particularly if your loss was later in gestation age. And I think a lot is made of labor induction. If you're on social media and are getting fed Instagram reels about birth, there's a lot of information out there about induction. There's sometimes a lot of fear mongering, honestly, about induction. So I want to break it down just a little bit with the pregnancy after loss lens. Labor induction is just the use of medications or other methods to start labor, as opposed to waiting for labor to start spontaneously. There's a lot of reasons why our provider might recommend an induction, and there's a lot of reasons why you might simply elect to have an induction or prefer an induction, even if there's not a specific health concern. Particularly for pregnancy after loss, I see this option chosen a lot, because I think that there's a lot of mental health benefits for a lot of lost parents when it comes to being able to plan a little bit that finish line of birth with an induction. Induction timing. Elective inductions are typically recommended to be done at 39 weeks. That's just kind of like in general a recommendation if there's no other medical reason to induce. Specifically for patients with a history of stillbirth, which it sounds like with some of us here, the ACOG and the Society of Maternal Fetal Medicine. So these are like the overarching organizations for obstetricians and MFM. They recommend 39 weeks generally, but they also suggest, I think importantly here, that 37 weeks to 38 weeks are also appropriate if that is what the birthing person is asking for. And, you know, they've had a discussion about it with their provider. I do see that 37 weeks, in particular, but, you know, 37 weeks, 38 weeks is something that I see a lot, in, people who've had, a lot, particularly people who've had a lot, kind of closely to the end of pregnancy. 37, the reason why 39 weeks is suggested is because 39 weeks is seen as the very beginning of full term. 37 weeks and 38 weeks are defined as early term, still term, but early, which means that there's a slightly increased risk of things like the NICU stay or lower birth weight. Oftentimes, though, you know, that trade-off is well worth it when someone is having after loss. It's something that they're aware of. They have decided that, you know, just the benefits of being able to induce and, you know, outweigh that slightly increased risk. And, you know, sometimes it's just, you know, it's all that they can come in and, you know, it makes sense for them. I want to talk a little bit about what the experience of having an induction is like, if that is the choice for you. And I talked about this a little bit already, but, you know, that very well may be the right choice for you if, you know, the idea of having a mental finish line is really going to help you. Being able to have a date on the calendar, I think sometimes is really empowering and just, you know, helpful to a lot of people. It gives a lot of clarity and, you know, just the ability to know that that's what you're counting down to, I think means everything to some people. And it also might allow you to just know who's going to be on call and have you, you know, pick your doctor who's going to be the one to help deliver your baby. You know, for a lot of those reasons, and just kind of, you know, mentally, emotionally, for many foster parents, they can feel like that's the safest option to bring their baby home. You know, that said, an induction is a lengthy and involved process, and I want to make sure that if that's what you choose, you know a little bit of what that experience might be like, so that you can help ensure it's a positive experience. So, you know, first off, duration-wise, it can take a long time. You know, multiple days would not be uncommon, especially if this is your first birth. If it's not your first birth, you know, even if you've had a loss through your prior birth, it does tend to be shorter, but I think it never hurts to prepare for a longer length of time and being pleasantly surprised if it goes faster than that. Because it can take a while, I think it's important to bring, you know, distractions and comfort items. We talked about comfort items a little bit already. But, you know, have picked out a couple movies or books or magazines, whatever, something to get your mind off of it. And that, you know, you can have kind of up your sleeve if you're, you know, find yourself looking for that. As far as, you know, how you'll feel with the comfort and movement, even if the plan is to get an epidural, still expect to feel a little bit of discomfort, and have a plan for some coping strategies. There are parts of the induction, even if it's not, you know, full on active labor and with, you know, regular contractions, that are going to feel a little uncomfortable. Not least of which you'll have monitors kind of, you know, on different parts of your body. You'll have the monitors on your belly that we talked about. You'll have an IV in your arm, most likely. You might have a blood pressure cuff on your arm. You might have a pulse ox meter on your finger. And with all those things, moving around, you know, is something that you can and should do if it feels right to you, but it just might feel a little bit awkward at first. You have to wheel around that IV pole. You might have to unplug from the machine if you're looking to get up and move around the room. It is possible, certainly, but just might get a little bit getting used to. Some other coping strategies, many inductions begin overnight. If that's the case, I really recommend prioritizing your rest and a nap during that day. Talked about this already, but, you know, helping pass the time with planned distractions or breaks. I think one thing that, you know, can help really mentally is, you know, closing the blinds, lowering lights if it's nighttime, opening blinds, turning on lights if it's daytime, just to give yourself a little bit of like a mental passing of time feeling. And I recommend, you know, eating a good meal before your induction. your hospital policy will most likely be a clear liquid diet once Pitocin starts or once active labor starts. If you're worried about that, I would ask your provider about bringing snacks. That might be something that is possible or even recommended, especially prior to active labor. Okay, I want to talk a little bit more too about labor comfort measures. This is kind of like, the big question that you'll often hear is epidural or no epidural. There are plenty of other options too that you can kind of mix and match. But the epidural is the most commonly elected option. It offers the most complete pain relief, which is probably why it is one of the most popular options. That means it's the best if your goal is as much pain relief as possible. It does mean that you have a reduction in mobility most often as well. You will likely not be able to walk or stand up or move around once you have the epidural. There's a couple other options too as far as pain medications. I've listed them here: nitrous oxide or IV pain medications. If you don't want an epidural or can't get an epidural for some reason, those are other options. They do less complete pain. I hear it described sometimes not how you don't feel pain, but you care less about it. Those are sometimes options available at hospitals as well. And then on the non-medication side of things, there's things that you can do like meditation, counter pressure massage, breathing, words of affirmation, movement. I find that movement, like especially rocking or swaying, that type of repetitive rhythmic movement sometimes help people cope with contractions and that sensation. There's also some options that fall under what's called the gate control theory for pain, basically giving your body a sensation that distracts it from the sensation of pain. There's something called a birth comb, which is just a regular comb, and you squeeze it really hard in your hands, and that intense sensation can sometimes help distract your body from feeling pain. There's a machine called a TENS machine that like sends electrical pulses on your back. That does kind of the same idea. One less common option is something called sterile water injections, and that's where sterile water is injected in very small quantities and it kind of forms a little bubble. It's done on your back typically. And for whatever reason that can help do the same thing, kind of distract your body from the sensation of pain, especially if you're feeling contractions while sitting in your back, which happens for some people. I'm going to try to speed up a little bit because I'm just keeping track of time and I do want to keep a good chunk of time for Q&A. But I want to talk a little bit about the epidural process because that'll be just statistically what a lot of us would choose. That process, we'll start with some preparations. You'll get a consult with the anesthesiology team. They're the team who performs an epidural. One thing to call out is often partners are asked to step out of the room during the epidural placement. If that's something that feels concerning or you're worried about, I would certainly ask the team about that during the consult. Yes, and as a reminder, you'll get slides afterwards as well. The placement of the epidural, you'll get a needle, you'll get some lidocaine, an injection of lidocaine to numb the skin so that you hopefully don't feel pain from the placement of the epidural itself. The epidural, what it is a catheter, a very thin catheter in your back that administers medication. There is not a needle that stays in your back after the epidural is placed. It is only to place the epidural. And it takes some time for the epidural to start working. So I like to say that, it makes sense to try to pencil in about an hour from asking for the epidural to actually having it work. That gives time for the team to, come to you, which depends on how busy the unit might be. Sometimes that can take a little bit of time just to have the team in the room. And it also takes a little bit of time for the epidural to start working. If you're still feeling pain after the epidural should be working, if that's something to communicate with your nurse and the anesthesiology team, there are top ops that they can do, the things that they can do to just make sure that you're more comfortable. Okay, Delivering your baby in a vaginal delivery. Pushing. Pushing is generally a very physical endeavor and requires effort. Sometimes I think that, again, if you're on social media, people sometimes talk about pushing, like it's a very gentle thing. You should be able to breathe your baby out, that type of thing. In my experience, it is something that requires work. In terms of pushing positions, you will likely be coached to push on your back and to hold your breath. And the reason for that is because generally providers find that that is the most, effective. That's the pushing position or the pushing technique that is helping baby come out faster. And that's the reason for it. If that's feeling like that's not working for you, that's something that, you can talk about with the team while you're there. Just know that, that's the reason that they're likely suggesting pushing on your back and holding your breath. Once delivery is imminent, pushing can take a while. If it is your first time pushing, pushing is often much shorter if it is your subsequent birth. And your body just sort of kind of retains this muscle memory. Even if your prior birth was a loss, pushing, if you pushed, pushing is often much shorter for a subsequent delivery. If pushing is taking longer though, as you near delivery, as baby is starting to crown and you're finally, almost there, you may find that providers kind of rush into the room, more providers rush into the room. You might find more members of the OB team, you might have additional nurses, the peds team, the pediatrician team, or the NICU team, they might be called into the room, and that's usually done as a precaution, especially if baby had some heart rate tracings that were a little less reassuring. It's usually done as a precaution. I want you to try to remember that if all of a sudden a bunch of people show up in the room, it doesn't necessarily mean something is wrong. It just most often means that people are there just in case. Some routine things are immediate skin to skin and delayed cord clamping. That means baby comes right to your chest. For skin to skin, and delayed cord clamping is cutting the cord, clamping it technically, around half a minute to a minute after delivery rather than right away. Okay, I want to talk about this a little bit because I've seen this and I want, after we talk about C-section birth, this goes the same. I just think, I want to talk about it here because we already talked a little bit about, delivering with baby. This moment of meeting your baby is, I think, something that is naturally really built up in a lot of our minds when we're pregnant after loss. And I hope that it is everything, that you dreamed of and beyond. And, it's something about those first few moments of greeting your baby are surprising to you, they take you off guard. I think just give yourself lots of patience and grace. I do find that sometimes, you're just in a state of shock at first, and it doesn't quite feel real yet. And that moment, of release, because I think if that's a moment where, many of us finally let out a breath, but that moment of release might come later. It can resurface grief in an intense way that maybe you don't expect. If, either of those things happen, something unexpected happens where, meeting your baby is different than you envisioned, I want you to just be kind with yourself and patient. And, I said that your bond will come and you have a lifetime to build it. Okay. So we'll talk a little bit about C-section next. I think even if you're not planning a C-section, it's important to know a little bit about it because if an unplanned C-section happens, then sometimes knowing a little bit, I think makes it feel a little bit less scary in the moment. As far as preparation, you might be given pre-op instructions that involve eating and drinking restrictions. You might be asked to do special prep as far as trimming hair or a special cleaning wash to use in the shower that day. Once you're at the hospital, you'll consult with the anesthesiology team. And then usually the nurse team will do prep things like place an IV, you'll get a urinary catheter to help you drain urine during the procedure, and you'll likely get these leg compression sleeves. Those kind of squeeze your lower legs, your calves periodically, and help prevent blood clot. Once you're in the OR, you'll get an epidural or spinal block to make sure you don't feel pain during the procedure. And you'll get surgical prep like drinks, the infusion. They'll place monitors on you to track your vitals. It's only after you're fully prepped that the partner is typically brought in. So usually they're waiting outside while all this is happening. For the procedure itself, short to meeting baby, typically 10 minutes or less. The longer part of the procedure is after the baby is born. You'll have someone from the anesthesiology team be closely monitoring you during the surgery to make sure you're doing okay. OB team performs the surgery, and then there'll be other people in the room to help with it. The incisions on both your uterus and your outer skin are typically what's called low transverse. That's that horizontal bikini cut, and baby is delivered through the incision. And then the surgeon, the doctor, will cut the cord and manually remove the placenta. Immediately after the procedure, you'll be wheeled to post-anesthesia recovery before moving to the postpartum room. You can generally start breastfeeding if that's your preference, as soon as you're feeling up to it. Similarly with eating and drinking, you can start doing that in the recovery room. You just might be, encouraged to take it slow so that you don't feel nauseous or throw up. The urinary catheter that we talked about, that's removed around 6 to 12 hours postpartum. The leg compression sleeves may stay on longer until you're fully able to walk. You'll likely also be offered pain medication starting in the recovery room. My tip is that you'll probably get reminded of by your nurse if whoever's giving you the medication. It's like typically Tylenol, Motrin at least. It's easier to stay on top of pain than it is to chase it. So even if you're feeling okay in the moment, I would recommend holding on, taking your medications on whatever schedule is suggested. Okay, let's talk a little bit about what's called gentle C-section measures. So that's a term, sometimes you'll hear family-centric as well, but that's a term that generally describes this principle of having C-sections more closely mimic vaginal birth rather than surgery. One of the big options in a gentle C-section is a clear or lowered drape so that you can see the baby being born. Delayed cord clamping is usually done. That's actually routine, regardless of whether you request a gentle C-section or not. Some other things to think about are background music or dimmed lights, other than the OR lights that light up the field, but dim lights for kind of you and partner are. Sometimes they can do like a slower delivery of the baby after the head is born to sort of mimic the time that baby is squeezed in a vaginal delivery, and that is thought to potentially help baby expel fluids from its lungs. One other thing is, like we talked about, the example of my former client is more immediate skin to skin, so potentially baby can be handed over the drape right to mom's chest or parent's chest. And initiating breastfeeding is sometimes possible while in the OR while the rest of surgery is being done. If any of these appeal to you is something that you're curious about, I would recommend having this conversation again with your provider, well in advance during your prenatal visits so that you understand what is possible or what is routine bed at that particular hospital. And again, I just don't want any surprises if you're, asking this for the first time on the day of. For things like, immediate skin to skin, there are some relatively simple things that can be done to help facilitate that. Things like putting EKG leads on your back as opposed to your chest, things like putting the pulse on a toe instead of a finger, you know, simple things like that that we potentially possible and can make a big impact. And those are the things that, you know, to ask about and would make sense, I think, to remind the team of as those things are being done, as sort of pulse ox is being placed and as EKG is being placed. As far as what your experience might be like with a C-section, some common sensation experiences include this feeling of pressure on your chest. ORs are typically cold, so you might feel that even if you're getting warming IV fluids or, you know, other measures to try to regulate your temperature. You might experience shaking even if you're not cold. That has to do with just labor hormones oftentimes, and sometimes is a reaction to epidural. There'll be a lot of sounds and smells with the procedure. I think something that you can ask about and think about doing for yourself, if, you know, the benefit of planning in advance is bring headphones if you're worried about hearing things and you don't want to hear. Maybe even ask your partner to bring, like, you know, a tissue with some essential oils for you to smell something different than what's in the room, things like that. There'll be a lot of people in the room, and so of course people performing the surgery, but also people there to chart and use assist, and an anesthesiology team. You might feel nauseous. That's a common one with a C-section. You might feel itching. That's actually goes with the vaginal delivery as well. It has to do with the epidural oftentimes. You likely will feel a sensation of pulling and tugging. Again, this is birth, you know, C-section is birth. It's an intense experience for your body, just like a vaginal birth. So you might feel some pulling and tugging as baby is being born. And then another one is that you might, you know, hear conversation. You might hear conversation among the people in the room that's either about the surgery or about something else. Some requests to think about. If the cesarean is part of your care, it is a significant event. I think it's a very loving way to meet your baby, but it's a lot, you know, on your body and mentally too. So planning ahead for it, I think, is smart to help ensure that that experience is easier for you where it can be. Some things that you can think about asking, and again, you know, asking these things well in advance so that you, there's no surprises. You can ask if it's possible to have your support person in the room from beginning to end. You can ask if it's possible to not have casual conversation among the, you know, people doing the procedure. You can be asked to walk through in more detail, or you can ask to not know, you know, whatever works for you. There's a couple I'll talk next about are more technical. Sometimes research has shown that people are more likely to feel nauseous depending on how the suturing of the uterus is done after the baby is born. And sometimes keeping the uterus in place rather than lifting it up can help with nausea. If that's something that you're thinking about or worried about, you can ask about how your OB or MFM typically does that step of the procedure. One other thing that's less common, more emerging, is something called a TAP, local anesthetic. And that's where a local pain medication is injected during your surgery into that transabdominus muscle layer of your core, like the deep core muscles that you heard about in the Pilates classes ago. And that can help with pain control. It lasts for like 24 hours or something after birth, and that can help oftentimes with pain around your incision. And this last one, I think, you know, is widely available, but probably not as commonly used. But I would take up your provider or look in advance for PT recommendations, pelvic floor PT recommendations for after your C-section recovery. Sometimes I think that a C-section recovery is not given as much instruction or information around, and it's a major surgery, and you know, should be a priority to make sure that your recovery is as thoughtful as it can be. Okay, that was a lot of information on what you might encounter as you start thinking about your birth. I want to talk a little bit now about this idea of identifying your preferences as far as it comes to your birth, and start by just a reminder that you are still allowed to have preferences when it comes to your birth. Just because you know firsthand that bringing home a baby isn't guaranteed doesn't mean that healthy mom, healthy baby has to be the only thing you care about. Whatever it is for your birth, if you still want to have, your special music playing, if you still want to make sure that your partner has a certain goal, whatever it is, that is still valid. On the flip side, if you feel like I just want to minimize the decisions that I'm asked to make, like, I'm totally fine with, going with it. And like, we're just going with whatever is suggested, that feels fine to me. That's also okay. Whatever protects your peace and helps you feel safe, is the right choice for you. Similarly, I think that, it's important to tune into you and what it is that you specifically, want. I think that there's a lot of information out there about birth. There is sometimes an overwhelming amount of information about birth. And, I recommend just doing your best, as hard as it might be, to focus inwards and try to tune out the noise. What's right for you is going to be different than what's right for someone else, particularly if that someone else hasn't been through the kind of loss that you've been through. And so if you can, try to find opportunities to clear your head and just think about what it is that I want, plain and simple, and jot down some of those words that might come up and just let those guide you when you think through making decisions for this work. Okay, part of what you'll get after the workshop is just birth plan templates that I provide for clients. They're nothing crazy, they're straightforward, but just a place to sort of memorialize and put down on paper some of your thoughts as you plan for birth. There's one for planned vaginal birth and one for planned C-section. I did want to take just a little bit of time and talk about unplanned scenarios. I think I'll keep this one brief, and I also understand if this section is just not for you right now, if you're not in a mental space for that. Different things can come up with birth, and as much as I think that it would be so nice if it worked out that way, that if you've had a hard road in your past with pregnancy history, that you just get and deserve an easy birth. Unfortunately, it doesn't always work out that way. So I think it helps to just start to think through a little bit of some of the possibilities, and sometimes that can make it feel less scary if it does happen. But I'll leave this here, I think, for afterwards so that we have some more time for Q&A. One note on postpartum, there could be a whole workshop on planning for postpartum, and it's certainly not my intention to suggest that postpartum is the easy part, but I do also recognize that when you're still pregnant after a loss, planning for postpartum can feel just next to impossible. It can feel really tough to let yourself mentally go there for what happens after universe willing, get to bring baby home. That's okay. I think that, again, a recurring theme is be patient. There's time. There's plenty of time when you are ready. If you are able to start thinking about some things for postpartum, I recommend trying to put in place certain things now that you will likely find beneficial when you have baby home. One of those is continuing or starting counseling. That's, whether on your own or as a couple. Hopefully you are getting good support now. I recommend continuing that, even through the end of your pregnancy. Saying yes to support from friends and family. If people are offering help, take them up on it. You don't have to feel like you should just get through it because it's supposed to be hard. Say yes if people are looking to help you. One specific thing that can help a lot is setting up overnight help with the postpartum doula or night nurse if the budget allows, or if you can crowdsource funds for that. Sleep is, an important part of mental health, and if you can do something to help support, your sleep during this very tender, vulnerable time, I say do it. And yes, I'll just, summarize with this message that even though bringing home your baby safe is like everything that you want, the reality is parenting a newborn is still really, really difficult. And it is a loving thing to do for both yourself and for your family, moreover, to find ways to support yourself. And you should give yourself permission to do all of that. It's not about what you need, it's more about, what is going to be beneficial. Okay, before we move to a Q&A, I did want to just take a few minutes again to do a little bit of a closing thoughts, or closing meditation. Yeah, so if you will, feel free to close your eyes, or repeat after me, whatever feels right to you. This may be hard, but I am strong and capable. This may be hard, but I am surrounded by love and support. I cannot predict exactly what is to come, but I can surrender to the unknown. Let come what may, I will embrace it. I'm a loving mother, I'm a loving parent to this baby and the babies who came before. I'm embarking on this journey as an incredible act of love.